Design Thinking in Medical Education, creating a new school at Penn State University in collaboration with the Harvard Macy Institute.
Welcome. I'm Holly Gooding, co-director of the Harvard Macy Institute Program for Educators in the Health Professions and an assistant professor of medicine and pediatrics at Harvard Medical School. And I'm here today to talk about design thinking and designing a whole new medical school. So let's get started. I'm joined today by the 5 Penn State College of Medicine medical student design partners. So that begs the question, what is a medical student design partner?
Sure. So the 5 of us all applied to medical school and all applied to Penn State College of Medicine. And once we were accepted, they gave us an offer to come up to University Park and State College and help them pilot and test drive and design a new curriculum that will be starting this July. So we all gathered there and have been working for the past year to give feedback and try out new ideas for our new curriculum that will start soon.
So you all delayed the start of your medical education for a year so that you could design your own curriculum.
Correct.
It's really cool.
Yeah.
So we hear a lot about this design thinking concept that's informing your work. Tell our viewers a little bit about design thinking.
So design thinking in medical education. Here we are, 5 medical student design partners as critical stakeholders in the creation of a new curriculum. Our lens is clear. We don't have, or at least most of us don't have any previous roles in education. So we are trying, or at least Penn State College of Medicine is trying to harness our innate human qualities, our unique individual capacities to come up with a novel way of approaching medical education, new ways to learn, and taking our feedback and kind of fine-tuning these approaches to medical education.
So lots of medical schools are in the midst of curriculum reform, and many, if not most of them, are talking to students, getting their perspective. What's different about this design thinking approach going from the ground up?
Well, the design thinking that we've been enabled to do this year as a pilot program, as deferred medical students, allowed us to have faster iterative cycles of learner outcomes and feedback instead of later negotiating these outcomes with our faculty members. We can actually get feedback in real time and finely tune areas that may need work or further development, especially with a brand new overhaul of a curriculum. Having the ability to do that in real time can allow the Penn State College of Medicine and all of us to really streamline the process.
So it really is this idea of involving the student voice, one of the major end users of any curriculum, early and often, and revisiting that in a more of a rapid cycle prototyping kind of way to get to an optimal curriculum that's going to meet your needs as future students in the program itself.
Yeah, that's very true. Especially the co-creation of a learner-led curriculum has enabled that voice.
So this idea of applying design thinking to the design of a school, where does that idea come from?
The idea of having medical student design partners pilot a brand new curriculum actually was inspired from Olin Engineering College, a book called A Whole New Engineer. And they also had design partners that were blank slates and tried to come up with solutions and ideas that were never tried or used before.
Really exciting. So tell me what a typical week looks like for a medical school design partner. What have you guys been spending your time doing this year?
We've been spending our time testing out whatever our faculty mentors think will work next year and the years to come. So in that regard, we've been taking their ideas, and one idea was to do clinical immersions early and often. And so we actually this year have gone into clinics as what we think a first-year student might do and tried to test out the first-year student role. And then in the afternoons, we come back to classroom sessions and we discuss what we think went well, what we think could be improved upon, and then after that session, we'll say, all right, let's work on what we can work on.
So that's so interesting. Instead of designing a semester-long course in clinical immersion, letting it run with 40, 100 students, getting course evaluations, and then revising, you're trying out little bits and pieces of curricular elements and courses, and then giving that feedback right there to develop the curriculum that you will then do next year. Yeah, that's really exciting. So what's been the best part of this year? What's been your favorite part?
I think my favorite part, and I can only speak for myself, is the opportunity to meet people, networking, particularly opportunities like the Harvard Macy Week that we went to in Boston. So really going beyond the classroom, really getting out into the community and meeting people. And I think that's really important. One of our philosophies is kind of engaging students and getting them out. And so for me, that's probably been my favorite part and the most meaningful, I think.
Another great part of this year was just the amount of knowledge that we've acquired in regards to learning, cognition, metacognition, I think will be formative in the way we approach medical education and medicine and learning in general for the rest of our lives, in addition to some of the very special patient relationships that we were able to have and develop as entering first-year medical students, as medical student design partners. Those experiences are indelible.
And additionally, I think it's been wonderful to really get to play around with different educational pedagogical concepts and try them out on ourselves, try them out with our faculty members, see what works, and then continually adapt that. Prior to coming to medical school, I worked as a high school science teacher for a few years, and I loved that experience. And one of my favorite parts of that experience was getting to make a lesson and try it out, and if a lesson or a unit worked, then great, I could continue to advance that in a particular direction. If it didn't work, then I had the control and the opportunity to change it and to say, okay, well, what can I do that's better? And I was a little nervous coming into medical school that so often the structure of medical schools in general doesn't always allow for that reform is sometimes a little bit slower because there's so many moving parts in a medical school relative to one person's high school classroom. And also I was a little bit concerned that as a student, my voice and my ideas and the pedagogical skills that I learned wouldn't necessarily apply. They wouldn't necessarily be as useful. And so I found it wonderful this year to really get to try things out and use things from my past and from my peers' past that have been effective, see can they implement on medical schools, whether or not other medical schools have tried this, try it out, spend a few weeks working on it in a certain way, and then seeing where that goes. And I think that has been wonderful in the Medical Student Design Partner Year, and I hope that we can continue to use that sort of tinkering around opportunity in the future.
So it sounds like this design thinking is really capitalizing on your strengths, both as prior learners in undergraduate education and in your case as a teacher, Tom, and also giving you quite a taste of what medical school is going to be like with these community relationships, these patient relationships, and then really even exposing you to the whole world of medical education, which I would say that many students don't think about until maybe the latter parts of their year, even their residency and beyond. So there must have been difficult parts. What's been hard about this year?
Yeah, I think one thing that we've done is sort of develop a culture of education with some providers that haven't been used to teaching students, especially in our stage. So we'll be entering the clinics as first years, and they're usually used to third and fourth year clerks. And so one thing that's been difficult is starting to make that transition and sort of educate them on the culture of education we'll be bringing to the clinics. And so trying to be that person to do the diplomacy between the clinics and the providers in our program has sometimes been a little challenging and rough, but it's worked out really well in the end.
That's a good point, Jason. A big part of this year with design thinking and coming up with a brand new curriculum that's never been tried in medical education before was getting the provider buy-in, the healthcare team buy-in. It was challenging at times when other people weren't as excited about what you were doing, which we expected. And so firmly believing in what we were doing was key to continuing on forward and working on those relationships and showing these providers that this is a good thing, that having first-year medical students in a clinic engaging in sorts of patient navigator sorts of roles is beneficial to the patients, to the practice, and to grooming medical students starting out.
The concern that I had early on was how much power we had over our new curriculum. I came straight from my undergrad career, and entering this year, we all had a lot of power over what we could put into the upcoming curriculum. And I think for at least me personally, that was hard to deal with.
How many people will be joining you next year? Like, how many people were you designing for beyond the 5 of you?
Yes, we're going to have a total class size of 12 is what we're aiming for. So It'll be nice. I'm really looking forward to the small class size. I came from a small liberal arts college, and a lot of the classes I had were very small, around that number. And so I think having a medical school designed with that class size in mind is going to be really exciting.
So that is a lot of responsibility, designing for these other students who are going to join you. So let's talk a little bit about what you've designed. You've mentioned a couple of experiences like early clinical immersion, patient navigators. I'm curious, tell me more. What's a typical week going to look like in the University Park program that you guys have been designing?
Absolutely. So for the first year or so, the week will be similar in nature. Our students will spend about 3 mornings in a clinical immersion. It will be a longitudinal relationship that they develop in either a family med or an internal med clinic. There will be several providers, but that location will stay the same for them, and their role will change, but they will be there consistently. And that might be, Monday, Wednesday, Friday morning, so we'll stay with that. To accompany that, then we have our IQ groups, or inquiry groups, as we call them IQ groups, but they're inquiry groups. And those usually pair up nicely with the clinical immersions that we have. So we have 3 of those a week as well. They will continue on for some time in the students' education, and they are Monday, Wednesday, and Friday afternoon. So you can see that Tuesday and Thursday there's a lot of free space in there, or white space in there for our students to take the time to do independent learning. But kind of over the year and a half, the beginning part of that curriculum, we also have some other components interspersed, anatomy sessions, collaborative science tutorials, and other extracurriculars that I am sure our medical students will become involved in.
And you yourselves, of course, because a reminder to our viewers, you're going to be taking this very curriculum that you've designed. Absolutely. You mentioned these longitudinal immersions and IQ groups. Tell me a bit more about those.
Yeah, so essentially we're coming in, as Morgan says, several days a week to the same clinic, to the same primary care clinic, and the core thing that we're trying to build there is trust. So initially, in the first month of medical school, an incoming medical student does not have all the medical knowledge they need to be a doctor. That would be an unreasonable expectation on our students. But they do have a variety of other skills as a means of gaining additional skills along the way and gaining trust along the way within their healthcare teams. So the plan is not just to have those students work with one doctor and shadow them or try to clerk with the doctor or anything like that. At the beginning, we'll be doing a lot more patient navigation, care coordination sorts of skills, in addition to learning about other members of the healthcare team and finding ways to gain those skills, and in doing so, learn more about the healthcare system. So learning some nursing skills and doing some rooming with nurses as a means of patient interaction, getting an opportunity to spend time in between the rooming that the nurses would normally do, and when the provider comes in, to have one-on-one time with patients from the very beginning. Even if you don't have the medical knowledge, you can still learn someone's story, you can do patient navigation work, and you can gradually learn to get your medical skills and your narrative medicine skills going that way. And then when the provider comes in, you can start out by maybe doing more assisting roles, and over time work into a more clerkship role there. And the key to all of this is exposing our students very early on to many patients, and many patients in a primary care setting, such that they'll have a wide variety of medical issues that they're trying to work with. And so that will help our students hopefully have intrinsic motivation and curiosity to then go out and say, I met a person today and that person is struggling with pancreatic cancer. And I don't know a lot about pancreatic cancer as a first-year medical student, but I want to. So they walk in the classroom, they walk into their inquiry groups, they walk into their white space of study time, and they have questions that they want to answer, not that the textbook tells them to answer or that a worksheet tells them to answer.
So there's so much interesting to unpack there, Tom. The first is this idea of learning interprofessional roles. A lot of us struggle in medical education with how to offer meaningful interprofessional education, because of course we all work in healthcare and interprofessional teams, but you're going to be embedded in an interprofessional team and learning with interprofessional colleagues from the beginning. So that's exciting. And then it sounds like you're also going to add some value to these clinics. I'm thinking I would love to have an extra set of hand in my clinic to help room patients, get patients where they need to go, navigate our complex system. So is that part of the design as well?
Absolutely. I think both of those things are core to what we're trying to do in our clinical immersion. So as you said, with the health systems understanding, oftentimes in clerkship roles and in medical schools, the worry, or one thing that we're concerned about, is that the medical students will act kind of as mini doctors that eventually grow up into big doctors. And that's one thing that they need to learn how to do, but that's not the only thing they need to learn how to do in a clinic. They need to learn what everyone else is doing in the clinic because they're part of a healthcare team now more than ever. And so understanding what the nurses are doing and how that affects the patient, understanding what people at the front desk are doing and how that affects the patient, care coordination, nurse practitioners, physician's assistants, there's all kinds of people working as part of helping that patient. And so to work with those people to understand those roles and to understand the interconnections between them, and that doing so will help us as we grow up into, hopefully, clinicians that can navigate that team and work as one of the leaders of that team.
So tell me more about these inquiry groups in the afternoon. Is it pure discovery learning? Saw that patient suffering from pancreatic cancer, I'm going to go look up a resource, or are some of them set? How is that going to work?
So an inquiry group is when we meet Monday, Wednesday, and Friday in the afternoon after our clinical immersions. And a group of students will meet with a faculty mentor, and we'll sit down and we'll bring back patient cases that we saw in the previous week that interest us and that we have questions about. And we vocalize these together as a group, and we decide upon a couple that we think are interesting to discuss throughout the coming week on Wednesday and Friday. And throughout this process, we're writing clinical case summaries to get some practice on actually doing a history and physical in a safe environment where our mentor knows that we don't have the best skills, so we can get some practice there. And we're also coming up with some learning objectives with our mentor. And the idea is that we use these learning objectives as shared jumping off points so that everyone can have an equal footing on what we're studying in our white space on Tuesday and Thursdays, so that when we come together on Wednesday and Fridays, we can have a general idea of what everyone wanted to cover, but then we can go deeper. And after our sessions on Wednesday and Friday, we can ask more questions that we can answer on our own time.
What's also really exciting about these inquiry groups is that the contextual basis for our learning are our patients. We're not learning from textbooks. We are meeting patients, we're engaging with them in the healthcare practice, understanding all the comprehensive dynamics that are going into their healthcare. And after meeting these patients, we develop these clinical case presentations that can allow for elaboration and expansion of our curiosities. And it's liberating as a learner to be able to explore that instead of just being confined to what my assigned scripted learning objectives are. And so our curriculum is very asynchronous in nature, which, as science people may seem uncomfortable, but it's actually quite the opposite. It's exciting because you never know what you're gonna see in clinic. So it's galvanizing in a sense because it's not typical.
I think also by rooting it in the patient case presentation, as opposed to a specific list of diseases, you'll be able to expand that patient presentation to compare and contrast and to learn about other diseases that may not have come up in your patient practice.
Yes, so that begs the question, we are in an internal medicine or family medicine, a primary care sort of setting. There are going to be diseases or things inevitably that we will not come across, more obscure conditions, like Wilson's disease or PKU. And, a lot of people that are learning about our curriculum are curious about the sort of breadth and depth of our curriculum. How robust is our curriculum? How well is our curriculum going to prepare medical students as any other medical school? And to address these potential gaps where these obscure conditions have to be learned, have to be addressed, we have the collaborative science tutorials.
Yeah, so tell me a little bit more about those.
Absolutely. So as I mentioned earlier, and as Vanessa has been alluding to, we're very conscientious about these potential gaps. And one of the concerns we've had this year was actually basic science. Most of, if not all of our faculty mentors are clinicians. And so how do we account for that learning and that expertise that we need to look to sometimes because we have questions and then we have more questions and then more questions and we want answers. Part of what we're doing is we're looking at a model in which we use maybe a session every couple weeks, and then a capstone course that will invite faculty from Penn State's main campus as well as our colleagues in Hershey to really dive deeper into those diseases that we may not see or even diseases that we may have or patients that we may have worked with. Being that we have the clinical immersions up front, it gives us a little bit of scaffolding, right? So we can build on those learning that we've had. So we see even a diabetic patient, we didn't read about that, but we have, we didn't read about them in a book, we've met this patient. Taking it a little bit further with a biochemist, I remember Mr. Jones and now I want to keep pushing it further. Can you help me do that? And so that's one of the ways, is kind of focusing on that basic science and making sure that we get those answers that we want, that we may not get from the IQ group sessions. Another good example are the anatomy sessions we're working to put together. We're collaborating with, again, faculty from Hershey, but as well as faculty from Main campus. Something that we haven't really talked about, but we have a very small campus and limited resources, which again, we have to be very conscientious of. And so being a team or partnering up with people is something that we really enjoy doing, and it kind of goes back to interprofessional learning as well. But utilizing some of the facilities on campus to do cadaveric dissection, we have an echo pixel, which is kind of like a 3D machine. You can use CDs of scans of imagery and kind of work with that. Maybe working with some ultrasound, so Sonocyte, Sonosim, and kind of using all these resources to address those gaps and to continue to further our knowledge so that we make sure that we're comfortable with what we're doing and at the end of the day are ready to practice and take care of patients.
Well, it just sounds really exciting, and clearly you all have developed a real facility with some of the major topics in health professions education. We've talked about system science, interprofessional education, just the whole idea of curriculum design. Several concepts from the science of learning have come up. So I applaud you on that, and I'm curious where you see this leading your careers. Do you all have futures in medical education? I hope so.
Yeah, I think for myself, it's really given me a chance to see the backside, sort of how sausage gets made of curriculum development. And so coming into medical school, I had very little background in educational theory or education in general. And so this has really given me a curiosity to want to pursue medical education after I graduate.
Yeah, this experience has helped me demystify what medical school is all about. And having the perspective of this year and medical education and having the patient at the center of our inquiry, I feel will promote a lifelong, humanistic, holistic approach to our patients. Growing with a healthcare team, being a part of a healthcare team, never feeling as if I was a mini doctor once and now I'm a big doctor. The way that I approach medical education now is completely different from the way I would have if coming into medical school without this design year, without learning about medical education and learning and cognition. The way I approach medical education now is centered around my patient. So if I'm going to anchor things that I learn, it's going to be because of my patient. The intrinsic motivation to learn is, again, the patient, not for the exam.
And just to add, something that I think we all agree is very cool about our curriculum is that design thinking is not just this year. It's every year. It's who we are and it's who our campus is. It's what we believe. And so I think all of us have had our eyes open to this education, right, med ed, and maybe might go into it. But I think our future students might actually also consider medical education because they will also be part of the design thinking. So it's become so much a part of our culture that I think it's opened that opportunity up for everyone.
I think that's a great place to end. It's really exciting to hear about what you guys have been up to this year, what the future looks like. I'm sure you've given our viewers many ideas. So thank you all for coming to talk to us today, and thank you all for watching.